It's very important now, especially in radiology, as Dr. Ahmed said. So thank you very much. It was really informative. And now I'm glad to introduce Dr. Rana Mamdouh. She'll be talking to us today about the imaging of breast cancer molecular subtypes. Okay, Doctor.
Good afternoon, dear professors and colleagues. I will talk briefly about the imaging of breast cancer molecular subtypes. By the end of this lecture, we will know the introduction of breast cancer subtypes and the importance of imaging in subtype detection, imaging modality used, and imaging features for each subtype and clinical importance. Breast cancer is a heterogeneous disease, and it is no longer seen as a one disease, but as a group of biologically distinct subtypes. These are classified based on hormone receptor status, HER2 expression, and proliferation index. Understanding this classification is important because imaging features often reflect these underlying differences. Currently, treatment planning is based on not only on anatomical staging, but also, and perhaps more importantly, on prognostic biomarkers. Immunohistochemical staining of hormone receptors and HER2 allow breast cancer to be classified into different immunophenotypes. The most common type of breast cancer is the luminal phenotypes, which is characterized by a positive expression of hormonal receptors and usually benefits from endocrine therapy. Molecular subtypes of breast cancer. We have 4 molecular subtypes: luminal A, luminal B, human epidermal growth factor receptor 2, HER2, which is enriching this receptor, and triple negatives, which is negative for estrogen and progesterone and HER2 receptors. Estrogen and progesterone hormones receptors modulate the activity of certain genes that control breast cell proliferation, and HER2 is a member of epidermal growth factor receptor. Additional tumor markers include Ki-67, which is a proliferation marker. Luminal A is the most common subtype. It is near 50% of cases. It expresses positive for estrogen and the progesterone receptor, but yet negative for the HER2 receptor, and low in Ki-67. The most common. The second type is luminal B, positive for estrogen and progesterone, may be positive for HER2 receptors, and it's high in Ki-67. HER2 enriched is negative for estrogen and progesterone, yet positive for HER2 receptors, triple negatives, which is negative for estrogen and progesterone and HER2. Imaging modality use. Imaging play a vital role in screening, diagnosis, and staging, so for treatment. Firstly, we start with mammography, which is standard for screening, detection, mainly detection of calcification and shape of the mass. Ultrasound, it is a great value of evaluating palpable masses, especially in dense breast tissue, in addition to lesion characterization, as we'll discuss. MRI, sensitive and help for pre-surgical planning, and especially dynamic contrast enhancement pattern. And PET-CT, it is used for detection metastasis and evaluation tumor aggressiveness based on glucose metabolism, and so help staging and aggressiveness. Start with luminal A subtype. Luminal A subtype is the hormone receptor positive, characterized by its low proliferation and grows slowly, so it is the best prognosis. And it is the most common type of this molecular subtypes. Imaging feature usually the typical features of breast cancer: speculated mass, irregular mass, which show slow progressive enhancement pattern. With this correlate with excellent prognosis and lower grade. Luminal type B, also hormone receptor positive, but it has a higher Ki-67, more aggressive than luminal A. So in imaging, we show it is more heterogeneous mass and often have higher proliferation. Maybe have a satellite lesions. The enhancement typically faster than luminal A and more intense, but less than triple negative or HER2 subtypes. HER2 subtype. It is HER2 positive, negative for estrogen and progesterone receptors. It is aggressive, but is, often respond well to HER2 targeted therapy. Imaging feature mainly presented with suspicious microcalcification. It is the most important point at HER2 subtype. Non-mass enhancement and on MRI, and have a rapid contrast washing and washout, and in PET-CT it is reflect high metabolic activity. The last and most aggressive type is a triple negative subtype. It lacks all three receptors and make it difficult in treatment and highly aggressive with the worst prognosis. Imaging feature likely resembling benign lesion, rounded or oval mass, well circumscribed, hypoechoic on ultrasound with posterior acoustic enhancement, no shadowing, no calcification, and show highly aggressive features as rim enhancing, central necrosis, high T2 signal on MRI, and very high and FDG uptake on PET. Imaging modalities and its radiological assessment. Mammography, again, mammographic features considered to analysis. On mammography, we can comment presence or absence of microcalcification, presence or absence of a mass, presence or absence of architecture distortion. This example of case of a luminal E subtype, synthetic mammograph shows speculated distorted lesion, high density mass. This is a typical for breast cancer, we know. Another example for luminal type A, patient 80-year-old patient with luminal type A have a speculated margin, obscured on mammography, hypoechoic in ultrasound, and have posterior acoustic shadowing. And on PET-CT, it have a moderate uptake. Example of luminal type B. And a 53-year-old female patient presented palpable right breast mass. Mammograph show multiple irregular and distinct obesities in upper outer and lower outer quadrant and retroillular region. On the right breast, as you show in the image, on sonogram, one of the lesions correspond to the arrow in figure number OA, show irregular and non-circumscribed parallel hypoechoic mass with posterior acoustic shadowing. And second C, we show a PET-CT with the SUV max of 11. Example of HER2 subtype with a mammogram. It shows we have a focal asymmetry and architecture distortion, and we can't find a mass, and but the characteristic multiple polymorphic microcalcification. This is the most characteristic feature of HER2 subtypes in mammography. On ultrasound, show irregular, non-circumscribed or macrolobulated mass lesion, parallel, hypoechoic, and retroillular lesion. And we can see the microcalcification also in ultrasound. And and PET-CT SUV max reaching 15. This is an example for a triple negative case, well circumscribed, rounded mass with no evidence of any microcalcification. Second modality is ultrasound. Ultrasound, we comment on a B mode ultrasound, comment on the shape, orientation, margin, echo pattern, posterior acoustic shadowing or enhancement, and calcification. And you also can use contrast enhanced ultrasound or real-time elastography to comment on the enhancement pattern and the stiffness. This is an example of different subtypes with ultrasound. A is a luminal A cancer subtypes, significantly correlate with the tumor, non-parallel orientation, speculated margin, no calcification, and high stiffness with weak blood flow intensity. Luminal B, it is associated with the same character, but yet low stiffness because more necrosis. HER2 subtypes significantly correspond to the tumor. Microlobulated margin, microcalcification, and isoechoic pattern with rich in blood flow signal, and D for triple negative breast cancer subtypes, which is associated with oval-shaped, well-defined margin and rich in blood flow signal of the tumor. It is also another diagram to show the shape with ultrasound and the in contrast enhanced ultrasound, the increase in the enhancement when go to luminal A, luminal B, so HER2 and triple negative. The same with the stiffness with the shear real steel elastography. The MRI, the most sensitive imaging modality to detect breast cancer and assessing the extent of the disease, and this has a strong correlation with the molecular subtype in breast cancer. Pre-treatment MRI was reviewed to assess the tumor imaging featured according to the 5th edition of Spirat scoring, which include we comment on the lesion types, mass or non-mass enhancement, mass shape, oval, rounded or irregular, a mass margin, circumscribed, irregular or speculated, a mass internal enhancement, homogeneous, heterogeneous or RAM enhancement, and mass kinetic curve according to initial phase, slow, medium or fast, and mass kinetic curve, delayed phase, persistent, plateau or washout, and distribution, which is focal, linear, segmental, regional, and multiple. The correlation between MRI features and the tumor immunophenotypes revealed oval or rounded shape and with ring enhancement were most frequently observed as a triple negative or luminal estrogen receptor low positive tumors. Speculated margin was we see most frequently in luminal E and luminal B. A persistent kinetic curve were more frequent in luminal A tumors. And when a washout curve was more common in triple negative and HER2 overexpressed. Examples of MRI cases. First case have irregular unifocal mass with speculated margin. It is a typical for luminal type A. The second case, irregular mass, left breast, with satellite lesions. It is a typically for luminal type B. The third case, rounded unifocal mass with no evidence of calcification or T2 dots for calcification. It is a typical for triple negative. FDG PET imaging. Malignant cells show higher glucose metabolism and increased glycolytic activity as a result of increased glucose transporter expression compared to non-malignant cells. The role of PET-CT and breast cancer is in diagnosis, staging, prognosis, treatment, response evaluation, radiotherapy planning, and detection of recurrence. SUV max is a semi-quantitative value that detects the degree of FDG uptake. The density of FDG uptake in tumor is related to increased proliferation activity in tumor cells. So triple negative breast cancer has a more aggressive biologically than other subtypes, and it is associated with a poorer outcome than luminal subtypes. Examples of FDG PET CT scan, 43-year-old female patient with luminal type A. We show in A and P maximum intensity projection, well speculated mass lesion corresponding to speculated soft tissue density with SUV max about 17, and we show axillary meds. The second case of the luminal P, again, the CT features of speculated mass in the inner quadrant of the left breast, where SUV max was 6 and shows small sized left axillary lymph nodes with focal thickness reaching 5 mm, SUV max 3. Clinically, our imaging assessed and subtype estimation, biopsy guidance, treatment response, and understanding imaging phenotype enhanced multidisciplinary planning. To be summarized, the breast radiologist should be aware of the imaging finding of different breast cancer subtypes for proper radiopathology correlation. Imaging can provide a whole tumor assessment and a 3-group classification of phenotypes to better correlate with the pathological features. Divided to 3 groups to be modifying this. The first group include tumor present as a unifocal mass with speculated margin and persistent kinetic curve. This group is associated with a slow-growing breast cancer and related to luminal type A. The second group is presented with a mass, regular shape, margin, and heterogeneous internal enhancement and plateau or washout kinetic curve, multifocal mass lesion or multicentric, and this imaging phenotype represents more aggressive tumor, which is often associated with luminal type B or HER2 positive. The third group will well-defined mass lesion, oval or rounded shape, circumscribed margin, rim enhancement, and washout kinetic curve, and represent fast-growing carcinoma and was usually associated with triple negative subtype. Breast cancer subtypes exhibit the distinct imaging pattern, and radiological play a key role in diagnosis and therapy planning, integrating imaging and molecular data in the feature of the personalized radiology. Thank you.
Thank you, Dr. Rana, for your nice presentation. Actually, you made this subject very easy, and your images were very clear to differentiate between the different subtypes. Thank you. Any question for Dr. Rana?